Good afternoon to surgery clinical class for second year MBBS students. I am Dr. R Ghosal, Professor Surgery. Today's topic is examination of chronic abdominal pain. Now, probably you have studied in physiology what is pain, what are the types of pain, but I shall mention some points regarding our abdominal pain. Now, what is pain? Pain is a unusual discomfort that is expressed as pain. Now, in abdomen, the pain may arise from viscera, that is called visceral pain, and another pain can arise from peritis or peritoneal irritation, that is called the parietal pain. Now, you will ask, what is the importance of knowing this? Because the character of visceral pain and character of parietal pain is different. Visceral pain is not well localized but diffuse, and mainly it is felt in the midline. But in parietal pain is felt at the point of pathology. That is, if there is a inflamed appendix comes in contact with the peritoneum and peritonitis occur, that is felt at that site. But the pain in appendicitis before the involvement of peritoneum may be felt at epigastrium, may be felt at umbilicus, may be felt at your left iliac fossa. So it is not localized, it is diffuse. So this is the difference between your visceral pain and parietal pain. Now, regarding beginners in clinical methods, a patient may come to you in pain in various sites of body. The pain will be a major complaint in the gynecological cases, in the medical cases, in pediatric cases, in orthopedic cases and general surgical cases. But our topic is only the abdominal pain. Now, if a patient complains a pain in the abdomen, then immediately you have to ask the patient where it is felt. Number two, what is the type? Regarding type, it may be patient may tell you that this is a burning type. Other may call it is cramping type. Other may say that it is throbbing. So what is the Bengal meaning? In Bengali it will be the jala jala korche, chepe dhorche, kamre dhorche, othoba, or there will be a dab dab korche, throbbing pain. Another pain is cutting pain. So, is there any importance of knowing this? Yes. Throbbing pain indicates there may be a collection of pus or abscess, infection. The cramping pain indicates a colic, intestinal colic, uteric colic. This is cramping pain. Burning pain is present in your ulcer, gastric ulcer, duodenal ulcer. And cutting pain is felt in the anal fissure. That is, someone is cutting that part. So this is the type. So again, number one, you will ask the site where it is felt. Number two, what is the type? Number three, number three, how it is increased or aggravated by taking food or by walking or by jumping or jolting. So, how it is aggravated? Next, how it is relieved? How it is relieved? After taking drug, after taking food or taking rest. Some patient may tell, after taking rest this pain is relieved. Some patient may, after taking food it is relieved. One patient, after taking after taking drug, then only the pain is removed. So, again, what are the points then? You will ask, site of pain, where it is felt. Number 2, type of pain. Number 3, how it is aggravated. Number 4, how it is relieved. Number 5, any movement of the pain. This is also very important. Movement of pain means the pathology is at one side, but pain is felt at other side. So, movement of pain, there are 4 types of movements of pain, and from this movement of pain you can diagnose the disease. So, in briefly I shall discuss these 4 types of pain, and you will know the importance of knowing these, because just asking the patient where it is felt, then you can diagnose. Suppose, so movement of pain is of 4 types. Number 1, the referred pain. Number 2, radiation pain. Number 3, migrating pain. Number 4, the shifting pain. Now, radiation pain is that when pain is felt at a site away from the source, it is called referred pain. Example, the polycystic gallstone pain or gallstone colic. So, the source is gallbladder, but pain is felt at the right shoulder or on the scapular region. So, this is called, but pain may not be felt at the gallbladder region. This is called the referred pain. Number 2, radiation pain. When pain is felt at the source as well as a site away from the source, it is called radiation pain. Classical example is the renal colic, or due to renal stone, or ureteric colic due to stone in the ureter. Because here pain is felt till the kidney region and as well as to the symphysis pubis or upper part of thigh or the scrotum in male. This is called radiation pain. Next pain is not seen in our chronic cases, but it's seen in the migrating pain, in peptic perforation or gastric perforation. Pain starts from the epigastrium, then it comes into the right hypochondrium, then right lumbar region, then RIF or right iliac fossa. Because after perforation, the gastric juice first comes into the right upper abdomen, it irritates the peritoneum, so pain is felt in the right hypochondrium, then a fluid comes into the right lumbar region and pain is felt, then it comes into RIF and pain is felt. This is called migrate, just as if pain migrates. So, this is classically seen in the peptic perforation. Number 4 is shifting pain. This is very, very important, and you must inquire about whether such type of pain occurred or not. So, in first, pain is felt at umbilicus or left iliac fossa, but after 24 hours it is shifted to right iliac fossa. It is classically seen in the appendicitis. So, in appendicitis, the shifting pain in appendicitis, so first pain is felt at umbilicus or at left iliac fossa, then after 24 hours pain classically seen felt in, or patient complain of pain in the right iliac fossa. This is classically seen in appendicitis. So, the classical example of referred pain is the gallstone colic. Classical example of radiation pain is your ureteric colic or renal calculi. Then migrating pain, classical example is peptic perforation, and your shifting pain, classical example is appendicitis. So this is the fifth point. Then sixth point, whether there is associated features. What are the associated features? Common features are either whether vomiting and fever. So vomiting and fever are commonly seen in the appendicitis and your cholecystitis. So you will ask one by one this question when patient complains of pain. Then you have to write the history of present illness by elaborating all the points or including all these points. Then you take past history, whether there was any operation or not, whether similar pain occurs or not, and then patient was treated with drugs or not. So this will be also included in the drug treatment. Then your family history and personal history you must take, whether their addiction to smoking or alcohol or not. This is very important. Whether appetite is good or not, that is also important. Then bowel habits, bladder habits, and mainly the drug treatment taken. That is also important. So this is in short the history section. Then we shall come to examination, and in last class in abdominal lump I have shown you what will be the position of the patient. Patient will lie supine, the hip will be flexed at 45 degree, knee will be flexed at 90 degree, two limbs will lie side by the side of the body, and neck may be slightly extended. And our patient is asked to evacuate the bladder before examination, and patient is asked to take deep inspiration and expiration. Now, what is the planning of examination of a chronic pain? You know, the abdomen must be examined by four steps. Number 1, inspection. Number 2, palpation. Number 3, percussion, and number 5, auscultation. So first, you know, in the meantime you know how to inspect the abdomen. Number 1, inspection of the abdomen, shape of the abdomen. It is distended as a whole, diffuse distended, as a whole distended, or it is concave shaped or scaphoid. This is called scaphoid abdomen. It is concave. Number 2, whether it is moving with respiration or not. Number 3, position of the umbilicus, it is inverted or everted. Number 4, whether there is a localized swelling or not. And then any scar mark present or venous engorgement present. So this is from inspection. Then palpation. You know, palpation is two parts, that is superficial palpation and deep palpation. In superficial palpation, we shall examine whether there is a rigidity is present or not, whether any muscle guard is present or not, or any obvious lump or tenderness present or not. Then deep palpation, we palpate for the organs, organomegaly, or whether any lump or present or not, and a definite point of tenderness such as gallbladder point, the duodenal point, the McBurney's point for appendix, the colonic point for colitis, so and hypogastric point for bladder. So this point of tenderness must be examined, and among these most important is the GB point, gallbladder point. What is the gallbladder point? It is the junction of the right costal margin and the lateral margin of the rectus abdominis. So if you palpate deeply here, there may be a tenderness, and this tenderness indicates that gallbladder pathology may be there. Then duodenal point, you know the transparent plane to 1.5 inch to the right of this plane, there is a duodenal point, and if you palpate here, if tenderness is occurred, this indicates there may be duodenal ulcer. Then epigastric tenderness indicates the gastritis, also the gastric ulcer. Now left colonic point in the left iliac fossa indicates the colitis or colonic pathology. Now what is McBurney's point? McBurney's point, if you draw a line from the anterior superior iliac spine and the umbilicus, the junction of the medial 2/3 and lateral 1/3 is the McBurney's point. If you palpate deeply here, and if the tenderness is present, or tenderness present means patient will complain of pain, then it indicates that base of appendix is inflamed or tender. This indicates the appendicitis. So there are various causes of pain in abdomen, and this may be diffuse, this is not may be very much localized, but the planning of examination must include these 4 steps. Then next step, we have shown how to percuss the abdomen. That is 3 points. Number 1, the fluid thrill. Number 2, the septic dullness, and number 3, the river dullness. And number 4, auscultation with the stethoscope. What do we examine for with stethoscope? First, intestinal peristaltic sound. Intestinal peristaltic sound. Number 2, any abnormal bruit or abnormality in the aorta. And number 3, in special cases like pyloric stenosis, we put the stethoscope on the epigastrium and we shake the abdomen or the lower chest to see the succussion splash in pyloric stenosis. And another case, we use the stethoscope for auscultopercussion of the stomach, where the lower margin of the stomach is examined whether it is stomach is distended or not. So it will learn later on when we will show you the case of pyloric stenosis. But these are the principles of examination of the abdomen when patient comes with a pain abdomen. Now we will ask some question to the patient and will show how, if a patient comes with the pain, what questions we will ask, that we learn. This is very basics of basics. So this question must be asked whenever a patient comes with pain. আপনার তো পেটে ব্যথা, হ্যাঁ, কোথায় ব্যথা শুরু হয়েছিল? এখানে তলারটায়, হ্যাঁ তলারটায়। আচ্ছা, কিরকম ব্যথা ছিল? যেন কামড়ে ধরছে না কেটে দিচ্ছে? কামড়ে ধরছে। হ্যাঁ, তা কামড়ে কামড়ে যেন ধরছে। হ্যাঁ, আচ্ছা, হ্যাঁ, আচ্ছা, কি করলে ব্যথাটা বেড়ে যায়? হাঁটতে চললে বাড়ে, না খেলে বাড়ে, না কি করে বাড়ে? হ্যাঁ, না হাঁটলে বেড়ে যায় তো? হ্যাঁ, হাঁটলে বাড়ে। তাহলে ইট ইজ অ্যাগ্রাভেটেড বাই ওয়াকিং অর মুভমেন্ট। আচ্ছা, কি করে কমলো তাহলে ব্যথাটা? কমে কি করে? ওষুধ খেলে না এমনি এমনি কমে গেল? হ্যাঁ, হ্যাঁ, আচ্ছা আচ্ছা, এই ব্যথাটা কি ওখানেই থাকছে না নিচের দিকে নেমে যাচ্ছে, থাই বা এদিকে নেমে যাচ্ছে? না ওইখানেই ছিল, অন্যদিকে যায়নি, পিছনে বা নিচের দিকে নামা, উপর দিকে যাওয়া, হ্যাঁ, কোনো যায়নি। সো মুভমেন্ট অফ পেইন ইজ অ্যাবসেন্ট। আচ্ছা, এটার সঙ্গে কি বমি হওয়া বা জ্বর হওয়া? হ্যাঁ,
3-4 দিন আগে বমি হয়েছিল।
না, এই ব্যথার সঙ্গে বমি হয়েছিল কি?
না,
ব্যথা স্যার এমনি বমি হয়েছিল।
বমি হয়েছিল, জ্বর
হ্যাঁ
হয়েছিল।
হ্যাঁ, কিন্তু এমনি পায়খানা পেচ্ছাপে কোনো অসুবিধা নেই। হ্যাঁ, পেচ্ছাপে জ্বালা করা বা এইসব। আচ্ছা, so from questions, so in this case patient complains of pain in the left iliac fossa. Acha, now another onset is gradual or sudden. আচ্ছা, আপনার কি হঠাৎ ব্যথা শুরু হয়েছিল? হ্যাঁ, so the onset is sudden and it is cramping in type. So type, it is cramping, then aggravated. It is aggravated by the movement and not released by any rest, etc. It was only released by drug, and there is no movement of pain. There is no movement of pain. The pain is occasionally associated with vomiting. So this is all about the history of pain. Now examination. আপনি এবার শুয়ে পড়ুন তো। So patient position, the hip will be at 45-degree angle and knee will be 90-degree angle, and upper limbs will be by the side of the body, and patient should be exposed to the nipple line and to the upper part of thigh. Now so first inspection, what are we inspecting? The more or less the abdomen is scaphoid. The whole abdomen you see moving with respiration. So abdomen is moving with respiration. Umbilicus is inverted, not everted. There is no obvious scar mark, no venous engorgement. Clear? So this is about your. Now before examination you will ask the patient to evacuate the bladder, and you must explain what are you going to do. Then in cold season you warm your palm first by rubbing this, and then ask the patient Shasnin. So first superficial palpation, you first better to start away from the site of pain complaint. So if patient complains this, you start from opposite side. So by rolling movement you see whether there is a tenderness, superficial tenderness and rigidity, or any obvious swelling. This is also I have explained in the last class of abdominal lump. So there is a small swelling in the epigastric region. There is a small swelling in the epigastric region, but patient complains of pain in the left iliac fossa. Then you must know what are the quadrant of the abdomen. This is the mid-clavicular line to mid-clavicular line, transpyloric pain and transspinal pain. So it divided into 9. So your tenderness one by one. So patient has complained of this. So in deep tenderness we shall examine Shasnin jore. So first you for any hepatomegaly, then you examine your spleen for splenomegaly, then you see whether your kidney is bimanually palpable or ballotable. So kidney must be bimanually palpable and ballotable. So again no, so there is no obvious organomegaly. Now one point, so this is the gallbladder point, this is the lateral margin of the rectus abdominis, and this is the costal arch. The junction is the gallbladder point. So if ask the patient to take deep breath, Jojol Shasnin. So this is the GB point. This is the transpyloric pain. And 1.5 you have this is a duodenal point. So this is the spine, and this is the umbilicus. This is the spino-umbilical line. So this is roughly the medial 2/3 and 1/3. This is the McBurney's point. So if you whether he has tenderness or not, there is a slight tenderness is present. Similarly, the same point, spino-umbilical line on the junction of the medial 2/3 and 2/3, you palpate it, so it will be, there will be a tenderness. But surprisingly, a tenderness is present on the right iliac side, no tenderness on the left iliac. Then in the hypogastric point, this is the hypogastric or bladder organ, bladder is present, so there is no tenderness here. So these are the deep tenderness. There is no obvious other lump, there is no organomegaly, but there is deep tenderness in the right iliac fossa or appendicular point. So here I will not show you the how to show the purchase of the abdomen and your auscultation. And no abdominal examination is complete without the examination of hernial orifice. Kasun? Jore kasun? Hernial orifice, but there is a impulsion here and there is a epigastric hernia here. So hernial orifices, then testis, rectum and supraclavicular lymph node. That I have explained the importance of knowing examining these 4 in abdominal lump. So today I have only highlighted the points which are relevant in the examining in a chronic abdominal pain. Your history part is most important, and you have to write the history according to the points. What are the site, what are the type, what is the aggravating factor, what is the relieving factor, what is the movement factor, whether the vomiting and fever are associated with pain or not, and whether patient also notices any lump along with pain. And that is also explained in the last class. A pain followed by epigastric lump is found in the pseudopancreatic cyst. Pain followed by lump in the right hypochondrium is mucocele of gallbladder. Pain in right iliac fossa followed by a lump is appendicular lump, and pain in the flank following lump maybe in hydronephrosis. So all these about your examination and history and examination of chronic abdominal pain. Thank you.